Thank you very much, Big. When I was walking around yesterday, I was also at the Royal Society of Medicine. Do you remember when you invited me some 15 years ago and so on? Thank you for all your cooperation and friendship. So I have no problems, no relations. The role of the nose in snoring and sleep apnea. Give volume. This is a child, as you easily can recognize. And this child has an obstruction in the upper airway. And you see that the chest cask is different in children than in adults. You see the retractions of the cartilage of the chest, of the thorax. And the child is fighting definitively for life, and we wait for an arousal, because otherwise, can you imagine that? Yeah, I saw some ladies, and this is really what we received from a mother of a child who took these pictures. We can go endless in this. And the secret behind the pediatric obstructive sleep apnea syndrome, which is different to the adults, I will show you at the end. But first of all, there is Hippocrates, Levinus, Catlin, and a lot of old surgeons. They related to the problem of the nose and the snoring. And finally, they concluded, shut your mouth and save your life. But can you shut your mouth if you have an obstructed nose? It is very difficult, and this brings us to the question of the role of the nose in snoring and sleep apnea. There are some papers from Olsen, Cole, and others about the nose and sleep disordered breathing. As the nose constitutes the first port of entry of inspired air under normal condition, nasal pathology has a significant impact on airflow and hence potentially contributes to sleep disordered breathing. So is the solution that we have to correct the nose and then the snoring in sleep apnea is gone? No. Nasal breathing is the physiological way as well as during wakefulness as during sleep. There are a lot of papers, some very old ones, but less than 10% are oral breathers only of us, fortunately. The resistance of the upper airway. Think at the child you have just seen breathing. Where is the resistance? Is the resistance in the nose, or is it in the throat? During quiet nasal breathing, during wakefulness, the nasal resistance is about 50 to 60% of the resistance of the whole upper airway. Resistance of the upper airway awake, resistance nasal higher than oropharyngeal and during sleep. This is from Rundkrantz from 1996, and you can see that the resistance is higher in a supine position. And this is from my former co-worker Ferse, and you see when the patient is in supine position, the events per hour increase. Your wife will tell you that after a hard night, maybe after the opening yesterday. Resistance of the upper airway awake, nasal resistance is higher than oropharyngeal resistance, and the resistance of the upper airway increases significantly, so the nasal resistance is lower than the oropharyngeal resistance. Come. Why does an increase in resistance boost airway collapse? Increased inspiratory suction force, switch to unstable oral breathing route, because the nose is stable, the rest is not stable, disruption of nasal reflex cycles, and the role of nitric oxygen. This is the so-called Starling mechanism, and if you recall the movie with the child, how the soft pipe collapsed. So, and there are some papers which state this. And now we have a completely obstructed nose, sinus full of polyps, nose full of polyps. Does oral breathing boost airway collapse? Yes. Mouth closed, mouth open. And here you see during wakefulness, upper airway resistance is similar between nasal and oral breathing routes. During sleep, upper airway much higher during oral breathing. Here, spontaneous awakeness, if the nose is obstructed, higher chances of sleep stages, higher if the nose is obstructed. And then, do nasal reflexes maintain the upper airway open? It seems to. If we do lidocaine, then the as a surface anesthesia, then the AHI increases. Do nasal reflexes maintain the upper airway open? In conclusion, there are nasal reflex loops, but nasal reflex do not play a major role in the pathogenesis of obstructive sleep apnea syndrome. And then about nitrogen, I think we skip it because this is a long way. In conclusion, first, nasal obstruction, especially reversible, either artificial or disease-induced, is associated with snoring and mild OSAS. Secondly, a direct correlation between the degree of nasal obstruction and severity of sleep disordered breathing has not been found. And third, nasal obstruction is not the main factor in the pathogenesis of moderate and severe OSAS. But, ladies and gentlemen, but, oral respiration induced by nasal latex plugs in monkeys like adenoids and tonsils in humans make neuromuscular adaptation and lead to development of class 2 and class 3 open bite. This study was done when it was possible to undergo animal experience, and it was in 1961. And then the question is, the nose is the king and the tongue is the queen. Wherever the tongue goes, the air in the teeth follows. I will show you this video. Can you start it?
The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt.
So, nasal resistance is pivotal in obstructive sleep apnea syndrome in children. Therefore, treatment has to begin as early as possible to make the facial skeleton avoid posterior airway obstruction, like CPAP opens the upper airway. So if you want to avoid that you in the age of 50 or 30 receive a CPAP mask, you have to start with the treatment as early as possible. And this is a new message, ladies and gentlemen. The story of facial growth. At birth, our skull is about 35% 40% of the final size. At the age of 3, it's about 60%. And in the age of 5, 70%, in the age of 12, 90%. So if you want to avoid this Gothic arch and the mouth breathing, then you have to start with the ENT treatment in the age of 2, as our ancestors did, and with the orthognathic treatment in the age of 3. Airway obstruction, there are 4 points of obstruction: the nose, the adenoids, the tonsils, and the tongue. If you have hypoplastic tonsils like that, you have to open your mouth. There is no question if the problem is in the nose or wherever, otherwise you... Same story here. If you have adenoids which press the tonsils forward, you have an obstruction of the nose. And there we have this wonderful chat trial. I got 3 minutes more, which is funded by the National Institute of Health. And it's very interesting, as compared with the strategy of watchful waiting, surgical treatment for the obstructive sleep apnea syndrome in school-aged children did not significantly improve attention or executive function as measured by neuropsychological testing, but did reduce symptoms and improve secondary outcomes of behavior, quality of life, and polysomnographic findings, thus providing evidence of beneficial effects of early adenotonsillectomy. Scalloped tongue. Is the tongue really too large, or is it obstructive in the airway in the nose? Here, the septum. Should we wait till the age of 16 if the symptoms are in the age of 5? Or should we just wait until we have this orthognathic class 2 malocclusion due to missing ENT orthodontic treatment at 2, respectively 3 years of age? And maybe we should start with maxillary expansion before the sutures are closing. And this is a conclusion of really the father of sleep medicine. Maybe you know Christian Guilleminault from Stanford. He is a neurologist. And he concluded the upper airway is a collapsible tube, and its collapsibility increases during sleep. Extrinsic factors such as atypical craniofacial features may increase the risk of airway collapse. We review early development of orofacial structures and the anatomical variants that may be present at birth and can impact nasal breathing. After birth, there is a continuous interaction between orofacial functions and growth of anatomic features. We review the dysfunction identified to date that may impact orofacial development, leading to sleep disorder breathing through changes in the orofacial growth. The identification of risk factors ultimately leading to full-blown obstructive sleep apnea may allow early recognition of these factors and the development of treatments to eliminate early problems or at least decrease their impact. Thank you very much for your attention, and this is the invitation for Warsaw. Thank you very much.